this is Christy Alamon with NP Table Talk, DNP, and
Lala Reyes.
Margie Rodriguez.
And so we got a few requests, and these were like multiple requests from different viewers. But one of them was just like, "Oh, what do you think we should know? Is there any like pearls of wisdom you can give us?" So these are just going to be random little things here and there that we've learned over the years that we've been doing this. So just two little bitty ones that I thought off the top of my head was like the 2 midnights stays for inpatient, and also to qualify to go to like a skilled nursing facility or a rehab facility. Like you have to have 2 midnights before they'll even consider.
Oh, so wasn't it 3 midnights at one point?
No, I think it's 2 midnights.
Because I worked
Maybe
in
it was
long-term
3.
care. It used to be 3
Okay.
midnights.
Maybe it was 3, now it's 2.
Oh, well, good.
Well,
that's good.
And things are always changing in healthcare
Yeah.
for sure. So yeah.
Like during COVID, it was actually waived.
Oh,
So you
okay.
didn't even have to do like 1 midnight, but it is re-implemented. So it's usually a 2 midnight rule.
Good.
For inpatient, like to qualify for inpatient, and then also usually to transfer out. And then another thing people kind of forget is, they have Medicare and they need to go to a skilled nursing facility, for example, but they've already used their days.
Oh,
And
yeah.
okay, so you only get 21 days per year to use at rehab. So today I had that with the patient. Like he'd already used all his days. So now he's into a copay. So
Okay. So when does it reset? Like
the next year.
Oh,
wow.
Okay.
Wow.
21 days a year. Just remember that.
A year.
It's pretty devastating. And if you,
especially if you have a whole bunch of comorbidities at the
Yes.
end, that's a lot.
There's multiple CVAs.
Yeah.
It's like, how is that really, but he was going to have to pay the copay.
Wow,
to
poor
get
guy.
rid of
And that's hard. That's really hard. But the good thing is sometimes we have good social worker teams that can help navigate a way. And that's always just to be mindful of those things and seeing if they qualify for something else or assistance. Those are just different avenues, for sure. I know when my mom was ill, I really had to be an advocate for her to get into rehab because they tried to get her into a skilled nursing facility, but with her illness and everything that had been going on, she was a candidate for rehab. And sometimes they kind of gave me pushback, and I said, I know she qualifies, and so we kind of had to go back and forth. But again, just being the advocate even on that stuff, and if you can utilize rehab if they have the appropriate diagnosis and stuff is always another alternative way. But yeah, that's heartbreaking, if it's 21 days for a whole year. I mean, but
and then another one is for acute inpatient rehab. To be able to qualify for that, you have to do 3 hours of therapy per day. That's fun.
You're right.
So
yeah, you have to be able to participate in
3 hours.
Yeah.
Yes.
So 3
I
hours.
think it's the same when they transfer to a skilled facility too.
It's less. Yeah, it's less for.
It's not 3 hours.
It's not 3. Oh, okay.
It's not as intense, and that's why sometimes I know for me it was that, like for my mom to get into the rehab, it was really like I wanted those 3 hours.
But
if the patient came,
it's not just PT. It's an hour of PT. It's an hour of OT and possibly ST. So it does accumulate.
It's the same.
Yeah. Okay.
But so it's just 3 hours of therapy.
Okay.
But,
and it varies on what the needs of the patient is. For
so
sure.
they might do an hour and a half of PT, an hour and a half of OT, and not need any ST. As long as it's 3 hours, like that's the rule for acute inpatient rehab.
Yeah, for sure.
Well, that's a good pearl of wisdom.
Yeah, that is a good pearl of wisdom. I know for me, I get a lot of the questions of, well, how do you choose a blood pressure medication? And I know we've all are versed in the American Heart Association recommendations, the JNCC rules, and I know everything's not cookie cutter, right? As much as we try to put a cookie cutter kind of address, try to do this every time, you can't. And I tell my students specifically, like, okay, you have the ACE, the ARBs, right? Those are kidney protective. That's always something you want to consider. If you're diabetic, according to the American Diabetes Association, you should be on an ACE to have that protection as well. So that's something that you always think. However, I know for me, coming from a disabled elderly population to a commercial world, and I'm seeing 22, 23, 28, 29, 30-year-olds that have high blood pressure, am I going to put them on an ACE or an ARB? No. They're of childbearing age. So you have to consider age, comorbidities, what's best for this patient. and you think of, like you said, the labetalol or a thiazide or something like that. Metoprolol, we all like that will offset the blood pressure, the cardiac workload, those type of things. And so again, I've even seen some people switch from propranolol to the metoprolol with anxiety, different depending on what the situation was. And that was by cardiology at one point. So just a whole bunch of things to consider when you're doing the assessment for the patient and you're choosing that right blood pressure medication. So those are just always things to keep in mind. Calcium channel blocker and a thiazide for the African American population sometimes is better than the ACE and the ARB. Of course, it can be used in combination. But those are things that you always have to consider. Systolic blood pressure being elevated, what is that going to be? Calcium channel blocker. Those are all things that go through the mind when you're going into the room and talking about high blood pressure on the patient. And those were several pearls of wisdom when we were talking about blood pressure and what to consider. I'm sure more of you guys can think of more things specifically.
Their lab work.
Yeah, lab.
Are they hyperkalemic?
Right, if you're hyperkalemic, you don't want an ACE. You might want to hold that ACE. Always looking at that kidney function is always important. When it dips below that 30, do we really want them on an ACE? Those are the things you're like, we're going to hold this because of that hyperkalemia risk factor, and again, that's a great point to say, but those are, again, things that you need to be considering when you're choosing those things. And some of those are probably board questions, honestly. So keep those in mind.
You were talking about kids. What about kids and, coming into your clinic that you see
with high blood pressure?
Yes.
Okay, so that's a very good question. So for me, if they're hypertensive, first off, what's going on, And usually I deal with peds on an acute basis, but I would refer them to pediatrics for follow-up, because remember, when we're diagnosing high blood pressure, it's 2 blood pressures that are elevated, at least in the outpatient world, 1 week apart, plus depending on how high that blood pressure is. But
and then symptomatic.
Yeah, and symptoms. That's what. So of course, diet and exercise are the first things that you need to be considering with those things. But kids and pediatrics is a very good question. But I do like to leave that with the pediatric specialists.
And it is still first diet and exercise.
Still
diet and exercise.
Definitely.
You'll never go wrong with saying diet and exercise.
Yes. Right. So it's like, and follow up with your pediatrician.
Follow up with your PCP.
I mean, it might be the broken wrist right now, but that's probably what has it elevated. But those are a lot of good little pearls of wisdom just when it's coming to hypertension. And I do recommend that, which would go to even diabetes care. When we're talking about diabetes care, those SGLT2s, those Flozin, the ones that end with Flozin that make you urinate out that sugar. Those are always good. And that's also how I always remembered them, honestly, was that Flozin, because your urinary flow. But it would help specifically with that cardiac issue as well. Specifically, I'm not going to say names, but we also know what an SGLT2 is. And then we also like those GLP-1s, right?
Oh, absolutely, GLP-1s. In the orthopedic world with the GLP-1, just for those who are going into pre-op for elective surgery, those GLP-1s do have to be stopped at least 2 weeks prior to surgery, because there is an increased risk for pulmonary aspiration. Mm-hmm. So
in some settings, it's even 4 weeks. Like most recently, I had another patient that it was 4 weeks per the surgeon. Just FYI on that. Yeah,
I think it's probably surgeon dependent.
Very
driven on it.
I do have a pearl of wisdom that I just learned just last night. Actually, I was at a conference, and in regards to medications known as Prolia and Evenity, which are bone building medications. And it was interesting because we had a patient who came into the office who had vertebral fracture, but she was just diagnosed with METS. And it's everywhere, right? So now you're dealing with a vertebral fracture. Is it fragility because she does have osteoporosis, or is it pathological because of the cancer? So I was like, so then they were like, okay, well, do we need to stop the Prolia? And I'm like, well, that's a good question.
Mhm.
I think that's a question that we need to ask the oncologist because I'm
Mhm.
really not too sure. Well, last night I actually asked the expert on that question, and it's very interesting that that medication is not stopped. In fact, it's given at a different dose, at a higher dose, because
Wow.
cancer and osteoporosis, this medication will help that bone matrix to prevent any further
That's
fractures.
awesome.
So
regardless of the pathology behind it.
correct, regardless, because
Mhm.
now you're looking at two different, but now you're focusing on the cancer and how it also affects the bone,
Mhm.
and how you want to prevent further fractures. And you know, you could have the fracture, and I think I was discussing it with my physician and asking, you know, I don't know that the patient wants to have any surgery. He goes, well, he
Mm.
goes, you really have to consider that patients now with Mets still are lasting,
Mhm.
longer and living
Depending on what the diagnosis is and where it's
lives,
from,
right?
yeah. Mhm.
And especially if it's breast, or it's with
Mhm.
Mets, and
Mhm.
he goes, it would be a disservice for her if she didn't, because vertebral fractures are very debilitating.
Yeah, the pain in
And
it. You want them to
yes,
stay mobile. You want them to be
exactly.
moving around. Because I know with chemotherapy, it's performance status that is going to determine whether you're even a candidate for that radiation or that chemotherapy. And with bone, that's, I mean, really, you want that comfort level for that patient. So that makes sense for sure.
And then also,
Very good point.
with cancer, it makes you more hypercoagulable, so you're more likely to get a DVT or PE.
Especially if you're mobile.
That's
yeah,
what I'm saying.
yeah,
so
yeah.
the more you're mobile, the more likely you are to
Yeah.
have, one of the other
Yeah.
things happen and affect you.
Yes, yeah.
Oh.
So,
That's a
was-
great pearl wisdom.
It
you know?
was awesome.
Yeah,
I really
yeah.
enjoyed the talk, and if I can give kudos to Dr. Melbus, she was a new endocrinologist that I just met. She's in the Corpus Christi area, and she is focusing on the bone aspect.
Mhm.
And I think she did her residency or somewhere in specifically to bone, so she takes that to heart, and it's so nice to have somebody there too, to help, because we're still trying to start this bone metabolic clinic, and she is definitely a good resource.
That's awesome.
Yes.
That's awesome, man.
And that's another thing for South Texas. We do have such a high population of with patients with metabolic syndrome. So what I was talking about earlier is if their blood pressure is high, then don't forget to check their A1C. Let's counsel them on this, and then you need to probably check their lipids too, because normally they have the trifecta. Diabetic, hypertension, hyperlipidemia. It's like, well, I don't have any. Well, when's the last time you went to a doctor? Well, I've never been to a doctor. Okay, well, so always make sure you're checking all of those for any patient that is one of those, because chances are they probably have all three.
Yes.
And then another kind of little pearl thing is, you're not stuck in the place that you work at forever. We have so many options. Just always keep your options open. You don't want to burn any bridges, of course, but you don't want to really work somewhere and spend most of your days, and then at the end of the day, or all you do is you come home and you grind about work. So that is kind of like
you're never stuck in the job.
Yeah, but if all you do is, if every day is horrible, that's not how it should be. We're all going to have bad days, but really, your good days should outnumber your bad days. So that's also speaking to of the respect that you are, given, and we work for it. It's not like we just want respect thrown at us, but we're professionals. We do our job, so we want to be treated with respect. So it's something, in a previous employer, not directly, but in the same company. So if you're like, oh, it's like, what is the best I can be, right? It's like 0 out of 10, like how we rate pain, right? I'm going to say, oh, well, what's your pain on a scale of 0 to 10? Well, if your employer says you'll never be a 10, that's probably a good sign that you shouldn't be there anymore, because they're already telling you that you will never meet their standards.
Yeah.
So I think you can take that in two ways. Well, I understand that part, right? But when you're rating from 0 to 10, 10 is like the very best. And a lot of times I've heard, and I think in Maslow's
Hierarchy. Uh-huh.
is that you'll never be there because you're always striving to be better.
Mhm.
So you can go that, hey, yes, hey, you'll never meet my standard, or you know what, you'll never reach it because you're always striving to do better and better and better. So I think it can go in two directions in that aspect. But I do understand, when you do have
The certain tones that they say these things
the
in,
body
and
language,
yes,
all of that does,
and I think that's what depicts some of those places for sure. But yeah, you're right. You're never stuck in a place. If you're not happy, there's plenty of places in our area. But you're right. Don't stay in a toxic environment if you don't want to be in a
And don't
toxic
burn any
environment.
bridges either. But just,
Yeah.
you do have other options.
Yeah.
Yes.
Yeah, for sure. I mean, there's plenty of things, especially when we're talking about those type of things, for sure.
And sometimes it's just not your cup of tea. Like,
Yeah.
oh,
Well, it's not what you want to do as well. I think sometimes people will be like, oh, I like this, but I'd rather be doing injections, or I'd rather do ortho, or I want to specialize more in diabetes care. Everybody has those preferences, and that's for sure. And if you're miserable, like you said, then that's not a good thing, because it eventually affects you as a whole person, your family life, and everything else in between. And so, yeah, that's a good thing to know. And if you need help, reach out to somebody, talk to somebody on those things.
Our group is very big. I mean, we network with so many. So it's just getting in touch with somebody who may know something, or just ask, hey, do you know if anybody's hiring? But like Christy said, don't burn your bridge. I mean, you never know, because
it's a small community.
It is.
It's a small community, and people, your name gets around, and people do talk for sure. So that's a good world of advice.
Well, I think that's probably good for today. Please, join us next time. Follow us on YouTube, Spotify, Facebook. Email us, and it's all NP Table Talk. And send us any questions if you have them.
We like to answer them.
All right. Thank you.
Good night.